Today we will focus on thoracic viscera, which includes the chest and upper airway. We'll review anatomy, physiology, and how this knowledge applies to radiographic positioning. By the end of this lesson, you should understand the structures of the thoracic cavity and how proper positioning improves diagnostic image quality. I have added some visual learning tools here. If you guys want to check any of these out, these are all YouTube videos. Feel free to do so. Anatomy of the body habitus. Body habitus determines the shape, position, and movement of the internal organs. The following diagram shows the general appearance of the thoracic cavity of different body types. This we will see in the next slide. These are the four types of body habitus. Note the general shape of the thorax, size and shape of the lungs, the position of the heart. Knowledge of this anatomy is helpful in positioning accurately for the projection of the thorax. We also touched a little bit on this body habitus in chapter 2, and I explained the difference between hypersthenic patient versus a asthenic patient. Anatomy of the thoracic cavity. The thoracic cavity is bounded by walls of thorax. It extends from the superior thoracic aperture to the inferior thoracic aperture. The diaphragm separates thoracic cavity from abdominal cavity. So if you guys can see the picture that's labeled A, we can see the superior aperture opening, the trachea, the mediastinum, which is the center between the lungs, heart, the diaphragm, and the inferior aperture opening. The first picture is inside the rib cage. The picture labeled B, we see this without the rib cage, how it looks like, the right and left lungs, our heart, the diaphragm, and how the diaphragm separates the thoracic cavity from the abdominal cavity. The diaphragm is the primary or main muscle used for breathing. It is not an organ, but a muscle. So the picture this says master anatomy, it shows the diaphragm, which is in the brown and green. Then we see this picture showing from below the rib cage, and it shows how the organs look like inside. So we have our cavale opening, which is at the level of T8, right phrenic nerve, inferior vena cava, and thoracic duct. And then we see our esophageal hiatus at the level of T10, esophagus, vagal trunks, which is anterior and posterior, aortic hiatus, which is at the level of T12, and abdominal aorta. The thoracic cavity contains the lung and heart, organs of the respiratory, cardiovascular, and lymphatic systems, the inferior portion of the esophagus, and the thymus gland. Within the cavity are three separate chambers, a single pericardial cavity, and the right and left pleural cavities. These cavities are lined by shiny, slippery, and delicate serous membrane. Mediastinum is the space between the two pleural cavities. It separates the pleural cavities. It contains all thoracic structure except not the lungs and pleura. So the picture on the top shows the thoracic cavity and the mediastinum that separates the lung into right and left cavities. It contains the heart and its large veins and arteries, trachea, and esophagus. The bottom picture here, the patient or the person shows in a lateral position, and it shows what's the mediastinum bounded by. So anteriorly, it is bounded by the sternum. Posteriorly, we see the vertebral column. Superiorly, we see the superior thoracic aperture. Inferiorly, we see the diaphragm, and laterally, we see the lungs. Anatomy of the respiratory system. This consists of pharynx, trachea, bronchi, and two lungs. The air passage of these organs communicate within the exterior through the pharynx, mouth, and nose, each of which, in addition to serving other described function, is considered a part of the respiratory system. Now we're going to look at the picture. We are looking at the nasal cavity. This is the entry point of air. This is where all the germs, dust get filtered away, and it prevents it from going downwards toward the larynx. The trachea is also called the windpipe It's a strong tube that carries air from the larynx to the lungs. We see our pharynx, that's also called the throat. It's shared passageway for air and food. Below that we have the larynx, which is our voice box. It keeps the airway open and produces sound because this contains our vocal cords. Then going down we have our lungs. This is the spongy organ that contains the bronchi, bronchioles, and the alveoli. The bronchi has two branches that bifurcates from the trachea carina on going into each lung. The bronchioles is a smaller airway inside the lungs, and the alveoli are tiny air sac at the end of each bronchioles. Below that we have our diaphragm. Anatomy of the pharynx. The musculo-membranous tubular structure, approximately 5 inches or 13 centimeters in length. It serves as a passage for air and food. It's located in front of the vertebrae and behind the nose, mouth, and larynx. The pharyngeal cavity is subdivided into nasal, oral, and laryngeal portions. Here we see in the picture the nasopharynx, which is the yellow area. It's located behind the nasal cavity. It is the passageway for the air only, and it helps direct the air towards the lung. Below that we have the oropharynx, which is the green area. It's located behind the oral cavity, which is our mouth. It serves as the passageway for both air and food. This area is shared by the respiratory and digestive system. Then we have our laryngopharynx, which is the blue area. It's the lower part of the pharynx. It connects the pharynx to the larynx, which is our voice box, and the esophagus. Anatomy of the pharynx, and I also have a YouTube link there if you guys want to check out more about this. When you breathe in, air flows through your nostrils and it enters the nasal cavity. Air goes from the nasal cavity into pharynx, which is our throat. The region connecting the nasal cavity and pharynx is called the nasopharynx, and the part connecting the pharynx to the oral cavity is called oropharynx. Lastly, there is laryngopharynx, the part of the pharynx that is continuous with the larynx, our voice box. At the top of the larynx is the epiglottis, which acts like a lid that seals off food when we are eating so that food only enters the esophagus. If anything other than air enters the larynx, a cough reflex should occur to keep it from traveling further down into the trachea. I have discussed the top picture of the throat or the pharynx in detail in the previous slide. The nasopharynx, oropharynx, and laryngopharynx, and this shows how it is connected to each other. The bottom picture shows how the food travels from the esophagus to the stomach and how the epiglottis acts like a lid to prevent food from traveling in the airway. Again, this is showing how the food is traveling down and the epiglottis is preventing it from going into the airway. We also see our larynx, our voice box. The second picture here shows the position of the epiglottis for breathing, how that lid opens and lets the airway go through, and then the position of epiglottis for swallowing, how that lid closes and the food goes into the esophagus to the stomach. Oropharynx extends from the soft palate to the level of the hyoid bone. The base of the tongue forms the anterior wall of the oropharynx. Laryngeal pharynx lies posterior to the larynx. It extends inferiorly and is continuous with the esophagus. Posterior surface of the larynx forms anterior wall. The top picture here shows how the oropharynx extends from the soft palate going down into the level of the hyoid bone. Second picture here shows the anatomy of the pharynx, and it shows how the laryngeal pharynx lies posterior to the larynx. The larynx is the organ of voice, and it also protects the airway. It's a movable tubular structure approximately 1.5 inches in length, located below the root of the tongue and in front of the laryngeal pharynx. It's guided superiorly and anteriorly by the epiglottis and laterally and posteriorly by the folds of the mucous membrane. Suspended from the hyoid bone at the level of the superior margin of the fourth cervical vertebrae, which is at the level of C4, and extends to the junction with the trachea at the level of inferior margin of the sixth cervical vertebrae, which is C6. The top picture here shows the larynx and the subdivisions. We have the epiglottis, supraglottis, glottis, which is our vocal cords, and subglottis. Bottom picture here shows the hyoid bone at the level of C4, our thyroid cartilage, which we can also call Adam's apple, cricoid cartilage, thyroid, which is at the level of C5, and trachea. The anatomy of the trachea. The trachea is the fibrous muscular tube with 16 to 20 C-shaped cartilaginous rings in its walls for strength. The measurements for this is the diameter is approximately half an inch or 1.3 centimeters, and then in length it's 4.5 inches or 11 centimeters. The posterior aspect of this is flat. It is important to know that the trachea lies in the midline of the body, anterior to the esophagus in the neck. If we look at the picture here, we have our larynx, which is our voice box. Then we have the tracheal cartilage. The tracheal cartilage is elongated and has a hook-like process, which is called the carina, which extends posteriorly on its inferior surfaces. Then we have our right and left lungs, right and left bronchus, the bifurcation of trachea where it splits, and the bronchioles. Again, this is showing that the last tracheal cartilage has a hook-like process called the carina. Trachea divides or bifurcates into right main stem bronchus, also referred to as right primary bronchus, and the left mainstream bronchus, which can also be referred as left primary bronchus at the carina, which is at the level of T4 and T5. Each primary bronchus enters the corresponding lungs. So if you guys can see the picture over here, it shows the right mainstream bronchus, left mainstream bronchus, how it splits at the carina into two branches. Then on the bottom, it just shows the tracheal bifurcation, the right main bronchus and left main bronchus. The degree of difference in between that is 70. Then we have our carina. It shows the how the tracheal cartilage looks like, the membranous part of the trachea, and the right and left main bronchus openings as it travels down the lung. Anatomy of the bronchi. Right primary bronchus is shorter, wider, and more vertical than left. However, the position and size makes it easier for foreign bodies to enter the right bronchus. So if you guys can look at the picture here, it shows the right and left lung, and you can definitely see how the right side looks more vertical compared to the left. And then this is where it's easier for foreign bodies to enter. A good example would be a chest x-ray when we do it on a child or pediatric patient. When they swallow coins or anything, any foreign body, it mainly lands on the right side. This slide shows the branching system of the bronchial tree, which is the pathway air follows as it travels deeper into the lungs. The subdivisions of the bronchioles, the airway moves through a series of progressively smaller airways. If you can see, we have our primary bronchi, the first branch of the trachea that enters each lung. Then we have a secondary bronchi, which is branch within each lung. Tertiary bronchi, which supplies specific lung segments. We have bronchioles, which is very small air passages. The terminal bronchioles, or very minute tubes, the smallest conducting airways. These airways mostly conduct air, not exchange gases. The diagram here shows the transition of the respiratory zone at the terminal bronchioles, and the function begins to change. The terminal bronchioles connect the alveolar ducts. Alveolar ducts leads into the alveolar sac, and each alveolar sac contains the alveoli. This is where the respiratory zone begins. Anatomy of the alveoli. I also have a YouTube video here if you guys want to go check out more about this. Alveolar ducts ends in alveolar sac. It contains millions of alveoli in each lung. Alveoli are the functional unit of the lung and is where the exchange of gases take place. Oxygen and carbon dioxide are exchanged by diffusion in the alveoli. Several alveoli are grouped together to form the alveolar sac. The alveolar sacs are lined with epithelial cells called pneumocytes, which secretes surfactant that decreases surface tension so that the alveoli stay open. All right, in this picture, it just shows that in detail. We see our alveolar sac, and then how it contains the pulmonary artery and pulmonary vein, and how our bronchial look like. Anatomy of the lungs. I also have a YouTube video here if you guys want to go check out more about the anatomy. Feel free to do so. The left and right lungs are organs of respiration. They provide the mechanism for introducing oxygen into blood and removing carbon dioxide from the blood. The superior portion of the lungs contains the apex or apices. It reaches above the clavicles. The inferior portion has the base. It rests obliquely on diaphragm. It's lower in the back and in the sides than in the front. The sides is called costophrenic angles. It's formed by the points at which the chest wall and diaphragm meets. And then we have our medial border, which is the hilum. It's a concave depression located on the mediastinal surface. It accommodates the bronchi, pulmonary blood vessels, lymph vessels, and nerves. Then we have our cardiac notch. As the inferior mediastinal surface of left lung contains a concavity called cardiac notch that conforms to shape of the heart. So if you guys can see this interior view of your right and left lung, it shows the tracheobronchial tree. Then going down, we see the apex. We're looking at the lobes. Also on the left side, we have our superior lobe and inferior lobe. It has the oblique fissure between, separating the two. Then we have on our right side, we have our horizontal fissure and oblique fissure, which separates the superior lobe, middle lobe, and inferior lobe. The bottom we see here is the cardiac notch. Then we have our diaphragm, and then the bottom of the lungs is called base. The corners of in the corner it's the costophrenic angles. Then we have the pleural sac. It shows the visceral pleura, pleural cavity, and peritoneal pleura. The bottom picture here shows the how the hilum looks like in a lung. The hilum is a triangular depression where the structure that form the root of the lung enters and leaves. Through the hilum, the lung is connected to the heart and the trachea. Structures entering the hilum includes the bronchus, the pulmonary artery, the pulmonary vein, and the bronchial arteries and veins. Right lung is approximately 1 inch shorter than the left because of the presence of liver and is broader than left. It moves inferiorly during inspiration and superiorly during expiration. Each lung enclosed in a double-walled serous membrane sac called the pleura. The inner layer is equal to the visceral pleura, covers the lung. The outer layer is peritoneal pleura that lines the chest wall and cavity. We've seen this in the slide before. The space between the visceral and peritoneal pleura is called the pleural cavity. Each lung divides into lobes. Right has 3 lobes, and the lobes are separated by 2 fissures. So if you guys can see the picture that's labeled A, we see the right side of the lung, the lobes have superior lobe, middle lobe, and inferior lobe, and it's divided by the horizontal fissure and oblique fissure. Then we have left has 2 lobes and is separated by 1 fissure. So we have our superior lobe and inferior lobe, and we have it divided by the oblique fissure. All right, in this slide, we see two pictures. The first picture shows the parietal pleura, visceral pleura, and the pleural space in the lungs. So the parietal pleura is the outer pleural layer. It lines the inside of the chest wall and the diaphragm. The visceral pleura is the inner pleural layer. It directly covers the surface of the lungs. The pleural space is a thin potential space between the parietal and visceral pleura. It normally contains a small amount of fluid to reduce friction, and it maintains negative pressure, which keeps the lungs expanded. The lung stays inflated because it is pulled outwards by the negative pressure in the pleural space. And then here we see a picture of pneumothorax and then a chest tube being placed into the lungs to re-expand the lungs. So pneumothorax is when the air enters the pleural space could be caused from a trauma, a lung rupture, or a medical procedure. This is when the negative pressure is lost. The lung collapses inwards, and the chest wall moves outward while the lung shrinks. How they fix this medically is they place this chest tube inside the lungs. A chest tube is inserted into the pleural space, and it helps to remove the air or fluid, and then it restores the negative pressure. Once the air is removed, the lung re-expands. The normal lung function is restored, and the pleural layer returns to their normal relationship. This slide is a good example of what we are learning in our lab from last week. So this shows what happens to our diaphragm and lungs when we inhale and exhale air. So when air is inhaled, the rib cage expands as the rib muscles contract. And it looks, if you look at the diaphragm contracts and moves downwards. There's an arrow that shows how the diaphragm has contracted downwards. And the second picture shows how air is exhaled. The rib cage gets smaller as the rib muscle relaxes, and the diaphragm relaxes and moves upwards again. Here we see how the inspiration and expiration chest x-rays look like, and how it helps us to identify if there is a pathology. In this case, we see collapsed lung. An inspiration and expiration series may be done when ruling out pneumothorax. Expiration often will better identify an air which is outside the lungs and is in the pleural cavity space. Only 8 posterior ribs will be demonstrated above the diaphragm on a PA expiration. When we have an inspiration, usually shows 10 ribs above the diaphragm. So this is an image of a chest x-ray PA. It shows the right and left lung, how the fissures look like in an x-ray. So we see our horizontal fissure on the right lung and the oblique fissure that separates the superior, middle, and inferior lobes. Then on the left side, we see the superior and inferior lobes separated by the oblique fissure. Then we see our air-filled trachea, and then how it bifurcates at the level of T4 and T5, and it goes into the right mainstem bronchus and left mainstem bronchus. Respiratory system allows air to enter the lungs and for oxygen to diffuse into blood and route it to the body's tissue. We have the trachea here on the first picture. We have the human respiratory system, shows the windpipe. Then we have the bronchi, which is the right and left branches. Then we have the alveoli, where oxygen moves into the blood while carbon dioxide moves into the lungs to be exhaled. All right, in this slide we have a pathologies. This is taken from the Merrill's textbook. I would highly recommend to go over each pathology and look at their definitions. You can always look this up as a internet search and look how each disease process or pathology looks like in an X-ray. Again, this is pathology continued. Again, I would emphasize on looking this up on how these look like in an X-ray, but definitely go over each pathology and the definitions and what you can commonly see in a clinical or hospital setting. Anatomy of the neck is divided into posterior and anterior portion. The anterior portion of the neck contains the thyroid, the parathyroid glands, the larger parts of the submandibular glands. So here in the picture we see this patient's thyroid cartilage. It shows the thyroid gland. And then on the bigger picture here we see the epiglottis, our voice box or our vocal cords, the trachea, how the pharynx look like, esophagus, and then all the other labeled anatomy. Here we see the anatomy of the thyroid gland. It consists of two lateral lobes. The function for this is the thyroid regulates metabolism, growth, and energy expenditure. The lobe measurement is approximately 2 inches long, 1¼ inches wide, and 3/4 inch thick. It extends from the lower third of the thyroid cartilage, which is the level of C5, to the level of first thoracic vertebrae, which is at the level of T1. It's connected at their lower third by the narrow median portion called the isthmus. The isthmus is a thin strip of tissue that connects the two lobes of the thyroid, lies in front of the upper part of the trachea. Okay, here we see the anatomy of the parathyroid glands. It's a small ovoid bodies. It's two on each side. We have the superior and inferior. It's situated one above the other on the posterior aspect of the adjacent lobe of the thyroid gland. The function is four pea-sized organs in the neck that produces PTH uh, hormone. It's also called parathyroid hormone that regulates calcium, phosphorus, and magnesium in the body and bones. So if you can see here in the picture, it shows the superior parathyroid gland, the thyroid gland itself, and the inferior parathyroid gland in its positioning. The submandibular glands. The submandibular glands are the two salivary glands. It's located below the jaw on either side of the face. So in the picture here, we see our sublingual gland, and then we also see the submandibular duct. We see the parotid gland and the duct of the parotid gland. Then we have the ducts of the sublingual gland and the submandibular gland. Okay, we have our review question. Which lung has three lobes? So as we have learned earlier, our right lung has three lobes and our left lung has two lobes in much space taken by the heart. So it's the right lung. Review question 2. We have aspirated foreign objects are more likely to lodge in the so remember our right primary bronchus is more vertical compared to the left side. Carina of the trachea is where it bifurcates and splits into two, right bronchus and left bronchus. And then we have our esophagus. So I did talk about that since right primary bronchus is more vertical in shape, aspirated foreign objects are more likely to lodge in the right side. All right, the level of trachea bifurcation is so I did talk about this in the previous slide. It is at the level of the carina. Question 4, we have which structure is located in front of the vertebrae and behind the nose and mouth? And the answer for this will be D, our pharynx. All right, so we're going to go into the radiographic procedures. This is essential projections of the chest, lungs, and pleura. We're going to start with the essential projections of the chest. We'll learn about posterior, anterior projections, lateral projection, PA oblique projection, anterior posterior or AP oblique projection, AP projection, and AP axial projection. We will learn about the general positioning consideration for the chest. Okay, so patient preparation. Patient preparation for thoracic viscera procedures require removal of artifacts from anatomy of interest, like for example would be long earrings, necklaces, and clothing artifacts. Secure all patients' position in designated manner and location. So we are learning this in the lab. When we bring in our patient, we introduce ourselves. One of the main things that we check with our patient is if they have any artifacts, and then we do offer them a gown, and we can give them a designated area where they can put their possessions. All right, for general patient position, so we have two types. We have ambulatory patients who can stand upright or be seated erect. And then we have the non-ambulatory patients, determine whether air fluid levels are critical to diagnosis, may have to substitute a decubitus position if patient cannot sit upright. For in our case, if we're doing a chest x-ray and the patient cannot stand or sit erect, we can do their chest x-ray laying down in a decubitus position. Recommendation for IR collimation and radiation field size. So use smallest image receptor that will demonstrate anatomy. So in our case, we are using the 14 by 17 permerals. The collimate radiation field size to anatomy of interest. So we adjust the radiation field to 17 inches in lengthwise and 1 inches beyond the lateral shadows, but no more than 14 inches. The opposite dimensions are used for a crosswise IR, which is on a hypersthenic patient. The vertical dimensions may be less for smaller patients. All right, for source to image receptor distance, the recommended source to image receptor distance for chest radiography is at least 72 inches or 183 centimeters. And why we do this is to minimize heart magnification or minimize magnification of the heart and increase spatial resolution. So we could take a look at the picture that shows a 72-inch SID chest lateral chest projection done compared to a 40-inch SID lateral chest projection. There is a huge difference in between. If you see the heart, um, there is less magnification uh, in the 72-inch SID compared to the 40-inch SID. Identification markers, these are very important aspect for any producing any optimal diagnostic images. So right and left side markers must be included on each image. Avoid using digital annotation to put right side markers on images. Place side markers in the collimated exposure field, clear of anatomy of interest. So remember how we mentioned in our lab that we will teach you how to place the markers and how we're going to place it so that it is not in the anatomy of interest, but it is there because we do need markers for each image that we produce. For radiation protection, you have to utilize closed collimation. Gonadal shielding should be used according to state regulations or to reduce patient anxiety. Optimum technical factors. So in order for us to follow the guidelines for the radiation protection, we have to make sure we're collimating on the images. It is stated per standard protocol. We're not overexposing patients by opening up the collimation field. Gonadal shieldings are important, so we are teaching you guys in the lab how we're going to be shielding the patient. And if it comes to doing like sacrum coccyx x-ray and we cannot shield the patient, how we can alternate and shield patients by making them feel more comfortable during x-rays. And then with optimal technique factors, this is also very important in regards to using our KVP mass, and then you will learn more about these in your physics class. Patient instructions, explain and demonstrate position when possible. Respiration instructions are critical to image lung aeration. Exposures are usually made after the second deep inspiration, full inspiration, exposure after second full inspiration. Note, the two separate radiographs may be taken, one on inspiration and one on expiration, to demonstrate pneumothorax, diaphragm movement, presence of foreign body, and atelectasis. So we are doing the chest X-ray lab right now, and we're learning how it is very, very important for us to give breathing instructions to the patient. And at the moment, we are doing the exposure at the second deep inspiration. So knowing why we are doing this breathing instructions is very important for each particular projection that you're doing, and what difference does it make. So as like the note says, there are two separate radiographs taken on inspiration and one on expiration to demonstrate pathology, and you will know that you will get that orders from the physician um, to rule out pneumothorax, and you will know that we have to do those two projections, which will include inspiration and expiration. And then earlier in the slides, we saw the difference of what inspiration and expiration does to the lungs and how it helps us rule out pathology. And in our case, we looked at collapsed lung. Okay, so we have a PA chest. This is what we are learning in lab again. So patient position, we want them upright or either sitting, standing, um, or seated. Demonstrates air or fluid levels in the chest. It allows diaphragm to move to its lowest position. The top of the IR is 1.5 to 2 inches or 3.8 to 5 centimeters above the shoulders. So remember how we always mention that we do have to see that 1.5 to 2 inches above the patient's relaxed shoulders during a chest x-ray. Part position, we have patient faces vertical grid device. It's in mid-sagittal plane or MSP, centered perpendicular to IR. Weight equally distributed on both feet. Flex elbows and rest back of the hand, low on the hips. Depress shoulders into same transverse plane. And we have roll shoulders forward to touch vertical grid device. So a lot of you had questions like how close we need to be to the image receptor when doing a chest x-ray. So it has to, when we instruct the patient, okay, stand in front of the board, I'm going to have you roll your shoulders forward. It has to touch the vertical grid device so that that makes your chest closer to the IR. And then it gets these scapulae away from the lung field. The central ray is perpendicular to the center of the image receptor. It enters at the mid-sagittal plane and at the level of T7, which is our inferior angle of scapula. Exposure should be made at the end of second deep inspiration. So if you could look at the example here, it shows the patient who is wearing the white shirt. It shows the centering point at the level of T7, but it enters at mid-sagittal plane. And how we find our T7 is by palpating for the inferior angle of the scapula. And then exposure is made at this end of the second deep inspiration. Again, we give the breathing instructions to the patient. Take a deep breath in, blow it all the way out. Take another deep breath in and hold it exposed. And that's when it inflates the lungs fully. We gotta have to watch for the chest to rise up and down from behind our lead walls. What is the structure that's shown during a chest x-ray? So we see our air-filled trachea, our lungs, our diaphragmatic domes, heart, and aortic arch. So here you see it is labeled in this picture, labeled A, We can see our heart, our lungs, our aortic arch, our apex or apices of the lungs. We have the air-filled trachea, the diaphragm, and the costophrenic angles on the side. Evaluation criteria. The entire lung fields from the apices to the costophrenic angles needs to be shown. There should be no rotation. And how do we make sure the patient is not rotated for their chest x-ray? The sternal ends of the clavicles should be equidistant from the vertebral column. So if you look at if your clavicle where it comes and meets in the middle, it has to be equidistant from the vertebral column. The trachea should be visible in the midline, then equidistant from the vertebral column to the lateral border of the ribs on each side. So when we look from the middle to the lateral border of the ribs, it should look equidistant. And then this is when we look at our collimation field. So make sure we have the patient inside the collimation field. And it also depends on body habitus. Not all the patients you'll have the light showing on the side. So as long as you're at your 14/17 lengthwise, crosswise on a hypersthenic patient, you have to make sure they are centered correctly and they are in the 14/17 light field. Again, we are continued with the evaluation criteria. So scapulae projected outside the lung field. This is when we have the patient put their back of the hands on a lower portion of their hip, or we can have them wrap their arms around the X-ray board to get that scapulae outside the lung fields. The 10 posterior ribs visible above the diaphragm. So when we tell the patients to breathe in with the full inspiration, the lung inflates and the ribs also come up. So 10 ribs should be shown above the diaphragm. That shows that the patient was in full inspiration. Sharp outlines of heart and diaphragm should be shown. Faint shadows of the ribs and superior thorax vertebrae visible through the heart shadow. And we have the lung markings visible from the hilum to the periphery of the lung. Right, here we're going to learn about the PA chest and heart shadow. In the diagram, you can see your left atrium, right ventricle, and left ventricle. Okay, so we have the lateral chest, the patient position. It's either it's upright, either standing or seated. It demonstrates air or fluid levels in our lungs. It allows diaphragm to move to its lowest portion. The side placed closer to the IR is the side demonstrated in the image. So in this case, we see the patient standing in a left lateral position. Left lateral is routinely used to minimize magnification of the heart because it puts the heart closer towards the IR. The top of the IR is again 1.5 to 2 inches above the shoulders. Part position, the patient is in true lateral position. We want to make sure the mid-sagittal plane is parallel with the IR, but the mid-coronal plane, which is MCP, is perpendicular to the IR. Shoulders should be in contact with the grid. Extend arm overhead, flex elbow, and rest forearm on head. Place IV stand in front of unsteady patients. In our case, in the classroom, we have the holders that's attached to the wall bucky. You can either use that, or if your clinical site doesn't have that, you can always use a IV stand. Ensure patient is not leaning sideways or bending forward. This will help avoid rotation. The central ray or the CR is directed perpendicular to IR. It enters the patient at mid-coronal plane at the level of T7. Again, our centering is at the level of T7. How we find that is by palpating for the inferior angle of the scapulae, and it's at the mid-coronal plane or mid-axillary. Exposure is made at the end of second deep inspiration. Again, we tell the patient to take a deep breath in, blow it all the way out, take another deep breath in and hold it. Okay, what structures are shown on a lateral chest x-ray? So left lateral position demonstrates the heart, aorta, the left-sided pulmonary lesions, and the right lateral position demonstrates the right-sided pulmonary lesions. It also shows the interlobular fissure. So in the picture, if you can see, it shows the collimated edges for the left lateral projection of the chest. We have the lung apex, air-filled esophagus, right? In front of that, we see the trachea, the sternum, the hilar region in the middle, the posterior ribs, which is superimposed, the heart shadow, the diaphragm, and the costophrenic angles in the back. Evaluation criteria for a lateral chest. So the arm or its soft tissue not overlapping the superior lung field. Then we have the costophrenic angles and the lower apices of the lungs. No rotation is shown. So the hilum is in the middle or the center. We have the superimposition of the ribs posterior to the vertebral column. Sternum will be in profile and the trachea would be in the midline. So if you could see in this picture, it shows the no rotation, how it looks like in a lateral chest x-ray. So we have in the middle here, we see the trachea. Right below that, we have the hilum in the center. Superimposition of the posterior ribs in the vertebral column. We don't see that spiral effect in the ribs on the back. It's perfectly superimposed. And then we see the patient's sternum in the front and the trachea and the costophrenic angles look good. The long axis of the lung field shown in vertical position. We have the open thoracic intervertebral spaces and intervertebral foramina, except in patients with scoliosis. Penetration of the lung field and heart, sharp outlines of heart and diaphragm. So again, the long axis of the lungs would show in a true vertical position. You will see the open thoracic intervertebral spaces and intervertebral foramina. Um, Unless the patient has scoliosis, then those will be hard to see. Um, and then obviously you see the heart shadow. If you have proper penetration, you will see the lung field, and then you will see the sharp outlines of the diaphragm and the heart. All right, here in this picture, we see two chest x-rays. We have the PA and lateral position projection. Um, it shows the air fluid levels. So if you look at the projections here on the first one, anytime we have an air fluid level, it shows as a straight horizontal line. So this is the air fluid level in the patient's lung. This occurs when the air raises or fluid settles inferiorly. Um, it clearly shows the patient's upright. And then also on the lateral projection, you see the horizontal line shows the air fluid levels in the patient. Posterior anterior oblique chest or PA oblique chest. We have part position, patient position, and then we're looking at the CR. So you're going to look at the patient position. We have upright, which could be standing or seated erect. Top of the IR 1.5 to 2 inches above the vertebral prominent. Part position, the patient is rotated 45 degrees left anterior oblique or right anterior oblique. The side of interest is further from the IR. So that's the elevated side. This is done because we need to move the spine out of the area of interest. The shoulders in same horizontal plane, arms positioned out of the radiation field. The central ray is perpendicular to the IR. It enters at the level of T7 and the exposure is made at the second full inspiration. So the top picture we see here patients in an RAO position. This spine moves to the right, therefore we are interested in the left side. That's the elevated side. Bottom picture we have the patient in a LAO position, and it looks like the spine moves towards the left, so we are interested in the right side or the elevated side. And also notice their arm placement for the patient. Um, the side that is elevated, that arm is placed on top of the bucky to get that out of the way, because that is the side of interest. So we don't want the arm to be in the image. So we have to get it away. And then the opposite arm is we have the patient's back of the hand resting on the lower part of their hip. Okay, so here we see a picture of a RAO and LAO position and how it looks like in a radiograph. So remember, the right anterior oblique with the right side is down, the spine moves to the right, and the area of interest is the left side. The LAO, the left side is down, spine moves to the left, and the area of interest is the right side. Okay, for the PA oblique chest, again, the structure shown in the left anterior oblique position. The right lung feels the anterior portion of the lung superimposed by the spine. We have the trachea shown, the carina, entire right bronchial tree, heart, the descending aorta in the front of the spine, the arch of the aorta. The structure shown in a RAO position is the left lung field, anterior portion of the right lung superimposed by the spine. You see the trachea, the entire left bronchial tree, the left atrium, the anterior portion of the apex of the left ventricle, and the right retrocardiac space. Evaluation criteria for a PA oblique chest. So you see both lungs in their entirety. We see trachea filled with the air, heart, and the mediastinal structures within the lung field of the elevated side in oblique images of 45-degree. Maximum area of the right lung on LAO and the maximum area of the left lung on a RAO position. Here we see the in the picture we see the RAO position, and then the maximum area of the left lung. Okay, now we're gonna go into AP oblique chest. Patient position is upright or recumbent. The top of the IR is 1.5 to 2 inches above the vertebral prominence. The part position is 40 degrees left posterior oblique, which is LPO, or right posterior oblique, which is RPO. Remember, the side of interest is closer to the IR, dependent side, or the side down. This is to move the spine out of the area of interest. The arms are out of the light field, shoulders in same transverse plane. The central ray is perpendicular to the IR. It enters 3 inches or 7.6 centimeters below the jugular notch. Exposure made on second full inspiration. Top picture here shows a patient in a RPO. The spine moves to the left. Therefore, we are interested in the right side or the dependent side, the side that is down. The LPO, the spine moves to the right. Therefore, we are interested in the left side or the dependent side, and the side is down. Okay, so remember the LPO left side is against the IR. Spine moves to the right. The area of interest is the left side. And then for the RPO, the side the right side is against the image receptor, and the spine moves to the left. The area of interest is the right side. AP oblique chest, the structure shown on an RPO position comparable with LAO position. So the elevated lung appears shorter, heart and great vessels appear magnified. Evaluation criteria is both lungs in their entirety, trachea filled with air, lungs fields and mediastinal structures, maximum area of left lung on LPO, and maximum area of right lung on RPO. Okay, here we should see a picture of an AP oblique chest on a LPO position. Okay, here we have the visual of bone anatomy in AP oblique. Remember the RPO or right posterior oblique. The right side is against the image receptor. The spine moves to the left, and the area of interest is our right side. So we have our visual here of the bone anatomy. Patient's right in a right posterior oblique position. We see the right side is against the image receptor. The spine on the left moves. The area of interest is the right side. And it's also shown in a chest AP oblique radiograph here. The patient is standing erect, if you guys can see. We have the right marker on the right side. We have the AP chest, and it shows the patient position, could be the supine or seated upright in a wheelchair or stretcher. Um, this is used when patient is too ill to stand. So remember we spoke about our ambulatory patient and non-ambulatory patients. Sometimes you have to use this alternative view if your patient cannot stand or sit erect. Top of the IR is 1.5 inches to 2 inches above their shoulder level. Part position, you have to center mid-sagittal plane to image receptor. If patient's condition permits, you flex their elbows, pronate their hands, and place hands on hips to draw scapula laterally. Adjust shoulders into same transverse plane. Okay, the central ray needs to be perpendicular to the long axis of sternum and the center of the image receptor. It should enter 3 inches or 7.6 centimeters below the jugular notch. Exposure is made after second full inspiration. On this top picture here, we see the patient in a semi-erect position. Use 72 inches or 180 centimeters cells to image receptor distance if this is possible. Always use your marker on the image receptor or label the image to indicate the SID used. Also indicate the projection obtained, such as AP supine or AP semi-erect. Bottom, we see the patient is centered in a lateral position. We see the CR entering at the level of T7 mid-coronal plane. We have our jugular notch, and then right below that it shows the distance from our jugular notch to our T7. So 3 to 4 inches or 8 to 10 centimeters below your jugular notch. Right, for the AP chest evaluation criteria, we want to make sure we see the entire lung fields, the left and the right side. No rotation is seen. So the sternal ends of the clavicles equidistant from the vertebral column. Again, regardless if you're doing a PA chest or AP chest, this is important to remember. We want to make sure the sternal ends of the clavicles are equidistant from the vertebral column. If it is not, that means you have rotation. Trachea visible in the midline. Equal distance from the vertebral column to the lateral border of the ribs on each side. Clavicles lying more horizontally than in the PA projection. So this is a very good point here. A lot of students ask what is the difference between a PA chest and an AP chest. So the clavicles are lying more horizontally than in the PA projection. Approximately 1 inch of pulmonary apices seen superior to the clavicles. And then the pleural vascular markings visible from the hilar region of the periphery of the lungs. Okay, so this looks like the same slide that we had previously, so it demonstrates the same things. Have the patient as erect as possible. This helps prevent an engorgement of the pulmonary vessels and to allow gravity to depress the diaphragm. For a supine X-rays, these are less preferred due to shortened lung fields, magnified hearts, and lack of air fluids. So on the bottom we see here is a patient in an erect position, and then we have a patient compared in a supine position, and these are chest radiographs. So Looking at the supine position, we see the heart is more magnified, the lung field looks more shortened, and obviously there's a lack of air fluid levels. Um, and then on the erect patient, you can see the whole, the diaphragm, the costophrenic angles, the heart, um, and then the entire lung field. All right, so we have the AP mobile or portable chest X-ray. Here I have two YouTube links. If you want to take a look at these, it shows how a chest X-ray looks like in an AP cart chest and a AP wheelchair chest patient. Looking at the diagram here, it looks like this patient is on a gurney. The IR is placed right behind their chest. We have our central ray going down at the level of T7 into the IR. It says angle tube caudally to be perpendicular to the IR. Because of the patient is in a semi-erect position, we have to angle the tube to get that AP chest radiograph. Um, and then it shows here the patient in an AP chest radiograph is laying erect on the stretcher. 72-inch source to image receptor distance is used, or 183 centimeters from the source, and then it is angled caudally to match the image receptor. So here it shows this is more of when we are taking patient care and safety into consideration. Communication is key. So when we have a patient that has is on a gurney or on a wheelchair, and you're trying to put that image receptor behind them, we have to be very cautious on if they have any tubing or any machines that are plugged in. A lot of times, if we're working in an ER setting, we have patients that have oxygen tubes, we have patients who have the IVs. So we have to be very careful when we're positioning or putting our image receptor behind them. Never be hesitant to ask for assistance when lifting and placing the IR. The nurses at the ER or any clinical setting or imaging center setting there where you work at, there would be colleagues who will be willing to help you. So it's always good to have somebody assist you, so you're not interfering with the tubing or interfering with making it uncomfortable for the patient trying to move them on your own. So just make sure ask for assistance and when lifting and placing the IR, and be careful with any tubings and any machines that are connected to the patient. We just don't want to interrupt their treatment process while we try to get that radiograph. AP axial chest in lordotic position, or this is a Lindblom method. Patient position, we have the patient facing the tube upright, approximately 1 foot or 30.5 centimeters in front of grid. Top of the IR is placed 3 inches or 7.6 centimeters above the shoulders. For part position, mid-sagittal plane or MSP centered to midline of grid. Assist patient to lean backwards until shoulders rest on grid. Coronal plane of thorax is 15 to 20 degrees from the vertical board. CR or central ray is perpendicular to the IR or image receptor. It enters the mid-sagittal plane at mid-sternum, 3 to 4 inches or 7.5 to 10 centimeters below the jugular notch. Exposure is made at the end of second full inspiration. Structure shown in the AP axial chest lordotic position. We see the lung apices, the interlobular effusions. Evaluation criteria is the entire apices and appropriate portions of lungs. Clavicles located superior to the apices. Sternal ends of the clavicles equidistant from the vertebral column. Clavicles lying horizontally with their sternal ends overlapping only the first or second ribs. Ribs distorted with their anterior and posterior portion superimposed. Here in the picture, you can see the clavicles are away from the lung apices. You can clearly see the lung apices, and the clavicles are sitting up higher because of that patient position. Apiaxial projection. There's a note here. It says if the patient cannot lean against the bucky, you must angle the tube 15 to 20 degrees cephalad, entering at the manubrium. So here's a example shown in the apical view. If the patient cannot lean backwards on the board, you can have the patient stand straight upright, but then you have to compensate and you have to angle your tube 15 to 20 degrees and cephalic or towards the head, and it will enter at the level of the manubrium. Essential projections or decubitus position. We have the AP or PA projection, which is right or left lateral decubitus position. Then we have the lateral projection, which is ventral or dorsal decubitus position. All use the same collimated radiation field size, which is 14 by 17 inches or 35 by 43 centimeters. Okay, we learn about AP and PA lateral decubitus position in this slide. So patient position, we have lateral decubitus on right or left side. To demonstrate fluid, patient should lie on the affected side. To demonstrate free air, patient should be positioned on unaffected side. Very important to know this. This could be like a board exam question. Patient needs to be in position for 5 minutes to allow fluid to settle or air to raise. Top of the IR is 1.5 to 2 inches or 3.8 to 5 centimeters beyond their shoulder level. AP or PA lateral decubitus position. Part position. We have elevate body 2 to 3 inches or 5 to 8 centimeters if laying on affected side. That should be a true lateral without rotation. Extend arm overhead. We have anterior or posterior surface of chest against vertical grid device. As an example shown here, we have the patient laying down on the table. It looks like they have used some positioning aid or sponges to elevate the patient's body to make it a true lateral without rotation. We have the image receptor placed in front of the patient, um, and the arms are extended overhead. For a lateral decubitus position, the central ray is horizontal and perpendicular to the center of the image receptor. It enters at the mid-sagittal plane or MSP at 3 inches or 7.6 centimeters below the jugular notch for a AP and T7 for a PA. So very important to remember that. For a AP, it's below the jugular notch, and for T7 is for a PA projection. Exposures made on second full inspiration. Here is an example of a patient in a lateral decubitus position with arms extended up. The central ray is horizontal and perpendicular to the center of the image receptor, which is placed behind the patient. So on top here, we have a picture of a patient laying down. It shows the pathology demonstrated. Small pleural effusion are demonstrated by air fluid levels in pleural space, or small amount of air in pleural cavity may demonstrate possible pneumothorax. And then notice how this also points out the use of the decube marker or arrow on the image receptor. This is a lateral decubitus position, but this is the AP projection of the chest. AP or PA lateral decubitus position structures shown. It shows the changes in fluid position, presence of free air. The evaluation criteria for this is the affected side is shown in its entirety, no rotations of patient, so the sternal ends of the clavicles equidistant from the spine. Then the patient's arm not visible in the field of interest. Remember, we have to place the patient's arm over their head. Faintly visible spine and pulmonary vascular markings from the hilar regions to the periphery of the lungs. So in this picture here, we see on the top, it shows if they are trying to detect fluid levels, the affected side is always placed down. And if they're trying to detect the air levels, the unaffected side is placed down and the affected side is placed up. So it shows the air levels. Okay, here in this picture, we see the lateral decubitus position. The patient's left side is up, the affected side is down. So remember how I mentioned when the affected side is down, they're looking for the fluid levels in the pleural cavity. So this is X-ray is done to detect and confirm the presence of fluid levels. And if the left side's up, this is a right lateral decubitus position. All right, so lateral decubitus view shows the central ray going 3 to 4 inches below the jagular notch. Here the picture, I think it shows 3 inches. It's specialized projection to demonstrate small pleural effusion or pneumothorax. Lateral, ventral, or dorsal decubitus position. So patient position could be prone or supine. Body elevated 2 to 3 inches or 5 to 7.6 centimeters. Top of the image receptor at the level of thyroid cartilage. Patient needs to be in position for 5 minutes to allow fluids to settle or air to raise. Part position, we have true, prone or supine position without rotation, affected side against vertical grid device, and arms are above head. The central ray is horizontal and perpendicular to the image receptor. It enters at the level of mid-coronal plane, 3 to 4 inches below the jagular notch or dorsal decubitus, and at the level of T7 for vertical decubitus. Exposure is made after second full inspiration. Right, lateral, ventral, or dorsal decubitus position. Here we see the ventral decubitus. The patient is prone and a horizontal beam is used. And then we have the dorsal decubitus. The patient is supine and a horizontal beam is used. Then lateral, left lateral decubitus. We have patient lying on the left lateral side and a horizontal beam is used. Examples shown here, we have the patient positioned for lateral chest. They have used positioning aids to elevate the body. And this is the dorsal decubitus projection. And then here's how it looks like in a radiograph. So lateral radiograph in dorsal decubitus position, showing pleural effusion with pneumothorax. All right, what are the such structures shown in the dorsal or ventral decubitus position? We have changes in fluid position. If you can see in the X-ray, it's marked by this horizontal line here, and the arrows are pointing to it. We have the evaluation criteria. The entire lung fields are shown, including the anterior and posterior surfaces. The upper lung fields not obscured by the arms, so the arms are above their head. No rotations of the thorax. T7 in the center of the image receptor. Pulmonary vascular markings from the hilar region to the periphery of the lungs is shown. Structures seen on a posterior anterior PA chest X-ray. So number 1, we have the first rib. Then from number 2 down to number 10, we have the posterior aspect of ribs from 2 to 10. 8K, we have the aortic knob. Then we have APW, which is the aorta pulmonary window. Then we have the BS, which is only shown on the right side. This is the breast shadow. Then we have the carina labeled C. We have the CA, which is the colonic air. You could see in the diaphragm, below the diaphragm here. Then we have the CPA, which is the costophrenic angle. DA, we have the descending aorta. If you could see right where there's a lining going down near the heart shadow. Then we have gastric air right above the clonic air. Again, it's below the diaphragm line. We have the left heart border. It's labeled LHB. We have the left pulmonary artery. Um, we can see it on the left side. Then we have the right clavicle. It is outlined on the top. Left clavicle not labeled because we have that first rib showing over there. Then we have our right hemidiaphragm. Left hemidiaphragm is not labeled. So the right hemidiaphragm, it shows the line. The left hemidiaphragm has the gastric air and the clonic air right below it. Then we have the right pulmonary artery labeled RPA, and T, we have the tracheal air column, and then we have the RHP, which is the right heart border. All right, structures shown on the lateral chest x-ray. So we have our A marked here as aorta. We have the CPA, which is the posterior costophrenic angles. It shows on the back, and then we have on the lower back, and then we have the left hemidiaphragm, posterior heart border labeled PHP. We have the RA, which is the retrosternal air space, RHD, which is right hemidiaphragm, RMF, which is the right major fissure, and the scapula is labeled S, and then we have T for the tracheal air column. Here we see the chest x-ray images. It shows the 10th rib is visible on full inspiration. Again, we learned about this when we have the patient take a deep breath in and hold in the end of second inspiration. We should be able to see 10 ribs above the diaphragm. So, and then on the labeled x-ray here, we see the clavicles labeled in this blue. And then we have the great vessels and the heart. We have it surrounded by the red markings, and then we have our orange line going where it shows the diaphragm. Then we have our stomach on the left side, and the liver is shown on the right side um, below the diaphragm. Okay, this is the lateral projection of the chest. Earlier in the slides, we learned about the structures that we are supposed to see in the lateral chest projection. So again, we have to see the heart, the aorta. If it's a left lateral position, we're supposed to see the left-sided pulmonary lesions. If it's a right lateral projection, then we need to see the right-sided pulmonary lesions. Obviously, we see the hilum in the center, we see the trachea in the midline, and then the sternum should be in the in profile. Okay, in this slide, we see the air fluid levels in an upright PA or lateral projection. The presence of both air and fluid in the thoracic cavity. The air and fluid levels shows as a straight horizontal line. This occurs when the air rises and the fluid settles inferiorly, and it's clearly shown if the patient is upright or erect. Pathology of pleural effusion, an affected site is down. So this looks like a lateral decubitus view. We have discussed this earlier in the slides. What this image is showing is the affected site is positioned down to demonstrate the pleural fluid. The arrows that are indicating in the red, they are showing the layering fluid within the pleural space. Why do we have to do this with the affected site placed down? Is because when the patient lies on the affected side, the gravity causes the fluid to layer dependently. And then this position also helps to confirm presence of pleural effusion. The fluid, if you can see here, it will appear as a smooth, homogeneous opacity along the dependent chest wall. And the lungs above the fluid, it remains appearing darker. Clinically, it's very important for us to perform this. It's because it helps guide with the diagnosis or the proper diagnosis and the treatment process. It is also useful before performing any procedures. Okay, here we see a chest X-ray and it shows pathology. How do you know this is a pneumothorax? So um, here you see the lung field and there's a arrow. There's a white arrow showing the pointing to your right lung, and it shows the visible pleural lung line. So the arrow is pointing to a thin, sharp white line in the lung area. This is the visceral pleura, and it outlines the collapsed edges of the lung. The only way I can hint is if you see the pleural line with nothing beyond it, think of it as a pneumothorax. The absence of lung markings beyond the pleural line is pneumothorax. The increased lucency on the affected side. Um, Also, you can see the pneumothorax side looks more darker than the opposite lung. This is caused by air accumulating in the pleural space. And then the collapsed lung, medially, the lung is pulled inwards towards the hilum. Okay, here we're going to briefly talk about soft tissue neck. So in the first picture, if you see, it demonstrates the radio-opaque foreign body in the airway or esophagus of the patient. The second image here shows the croup of the sepal sign. It's a AP soft tissue neck view that shows the subglottic narrowing. Example could be barking cough. And then the last image we see here is the lateral view of the neck. It shows ballooning of the hypopharynx. The arrows indicating the abnormal soft tissue widening, often due to retropharyngeal pharyngeal abscess, infection, or it could be inflammation. All right, so the last slide here, we talk about the situs inversus. This is a rare genetic condition where there is total transposition of the abdominal and thoracic organs. Um, Patients are usually asymptomatic. It's often discovered incidentally on X-rays. So the key to getting this radiographic cues of how we can identify it is the cardiac apex points to the right, the aortic arch is on the right side, the gastric bubble may be seen on the right side on the image, and the lung anatomy would appear mirrored. And why does it matter in radiography is it can be mistaken for patient rotation, incorrect image labeling, or markers are very critical in this case. If you're placing markers, that would be a good identifier if the patient has the situs inversus. And then the organs reversal must be documented before any surgeries, any procedures on any tube placements.